Good morning. Good morning. The Committee on Health, Hospitals, and Human Services is now on the record, and I want to say a pleasant good morning to all of my esteemed colleagues, the invited testifiers, central staff, and the viewing and listening audience. As always, we give thanks and praises to the Most High and blessings to all. I want to take a quick moment to recognize that March is National Kidney Month. A reminder that kidney disease affects 1 in 7 Americans, and that many who have it may not know they have it. Diabetes and high blood pressure are both contributors factors to kidney disease. And just to give you some of the early warning signs of kidney disease, there's a change in urination. You could have more frequent urination or urinating less. Also, you can have foamy or bubbly urine, dark urine, bloody urine, or tea-colored urine. Feeling unusually tired or weak, and also sudden swelling in the feet, ankles, and face. Of course, diabetes and high blood pressure, which contribute to kidney disease, are both prevalent in the Virgin Islands, and they are the leading causes of this disease. Early detection through simple blood and urine tests can make a life-saving difference. And I encourage all residents, especially those already diagnosed with diabetes, high blood pressure, or a family history of kidney disease, to speak with their healthcare provider about getting tested. Let us use this month, National Kidney Month, as a call to action to protect our kidneys, protect our health, and protect our families. Today's hearing is particularly significant. Our hospitals are in a state of emergency. That's right, they are in a state of emergency even though it has not been officially declared. And the people of the Virgin Islands deserve answers, accountability, and a clear path forward. We have 2 blocks on today's agenda. In Block 1, we will receive operational updates from the Department of Human Services and the Office of Disaster Recovery. Block 2 will receive a comprehensive update from the executive leadership of our territorial hospitals. We will proceed in an orderly manner, and remember to please silence all electronic devices. Mr. Clerk, can you please call the roll?
Senator Hubert L. Frederick.
Present.
Senator Hubert Frederick, present. Senator Marvin A. Blyden. Senator Blyden, absent. Senator Ray Fonseca.
I'm here.
Senator Fonseca, present. Senator Alma Francis Heiliger.
Present.
Senator Francis Heiliger, present. Senator Kenneth L. Gittens. Senator Gittens, absent. Senator Milton E. Potter.
Here.
Senator Potter, present. Senator Kurt A. Vele. Senator Vele, present. Mr. Chair, 5 present, 2 absent.
Thank you, Mr. Clerk. We do have a quorum and can proceed. Mr. Clerk, is there any correspondence to be read into the record?
Yes, Mr. Chairman. Correspondence from the Honorable Marvin A. Blyden, Senator. Dated March 24th, 2026. To the Honorable Ray Fonseca, Chairman, Committee on Health, Hospitals, and Human Services of the 36th Legislature of the Virgin Islands. Dear Mr. Chair, I am writing to respectfully inform you that I will be tardy to today's meeting of the Committee on Health, Hospitals, and Human Services. Please mark my initial absence as excused, and I look forward to joining the hearing at the earliest opportunity. Sincerely, Marvin A. Blyden, Senator, 36th Legislature of the Virgin Islands. That concludes the reading of correspondences, Mr. Chairman.
Thank you, Mr. Clerk. We will now begin Block 1, wherein the committee will receive an operational update from the Department of Human Services. Mr. Clerk, can you please read Block 1 into the record?
Block 1. Is mic on? Block 1. The committee will receive an operational update from the Department of Human Services on the administration of the Medicaid State Plan, including outstanding childcare balances and related financial obligations. The department will also provide updates on key projects, including the status of Herbert Grigg Home for the Aged and Queen Louise Home, the development of CMS-certified long-term elderly care facilities, and the construction timeline and relocation plans for the new Human Services facility. Additionally, the department will address strategies to reduce hospital borders through expanded long-term care capacity, as well as updates on federally funded child care initiatives and Head Start program expansion. Testimony should include clear timelines, measurable outcomes, and accountability benchmarks to ensure effective service delivery. Invited testifiers: the Honorable Avril George, Commissioner, Department of Human Services; Miss Adrian L. Williams Octalian, Executive Director, Office of Disaster Recovery. This concludes the meeting of Block 1, Mr. Chairman.
Thank you, Mr. Clerk. We will now proceed. Welcome, Commissioner Avril George. I see you over there in the Fritz Louettes. I want to start with a mic check over on St. Croix. If you can briefly give your name and identify yourself. We'll start with the Honorable Avril George. Commissioner.
Commissioner Avril George, Department of Human Services.
Assistant Commissioner Carla Benjamin.
Deputy Commissioner, Operation and Maintenance, Hugh Nicholas, St. Croix.
Can you repeat that?
Good morning, Akila O'Brien, Disaster Recovery Specialist.
Excuse me, Deputy Commissioner, can you repeat that your name didn't come over clear?
Deputy Commissioner, Operation and Maintenance, Hugh Nicholas, St. Croix.
That concludes St. Croix. We'll start with Assistant Commissioner, Ms. Dorset Phillips.
Good morning. Tasha Phillips Dorset, Assistant Commissioner.
Good morning. Lydia McGrath Purcell, Chief Financial Officer.
Good morning. Ralda Mason, Deputy Commissioner of Human Resources and Labor Relations.
Good morning. Gary Smith, Medicaid Director.
Good morning. Masika Lewis, Administrator, Office of Head Start.
Good morning. Tishma Tucker Lance, Administrator for the Office.
Put the mic closer to your mouth, please.
Good morning. Tishma Tucker Lance, Administrator for the Office of Childcare and Regulatory Services.
Thank you to all the testifiers and welcome once again. Commissioner Avril. Oh, I'm sorry. Yes, proceed.
Good morning. Kishma Vincent, Administrator, Senior Citizen Affairs.
Good morning. Sean Georges, Deputy Commissioner for Operations, St. Thomas St. John District.
Thank you. Thank you. Commissioner Avril George, you may proceed with your testimony.
Good morning, Honorable Chairman, Senator Ray Fonseca, members of the Committee on Health, Hospitals, and Human Services, distinguished colleagues, and the viewing and listening audience. My name is Earle George, and I'm honored to serve as the Commissioner of the Virgin Islands Department of Human Services. Joining me today are key members of my leadership team who play a vital role in advancing the department's mission, and I believe they all introduce themselves. Our team appears before you today to address critical issues that directly affect the safety, stability, and well-being of residents of this territory. My testimony will focus on areas of the highest operational and strategic importance: Medicaid State Plan modernization, long-term care capacity, early childhood services, and infrastructure redevelopment. These initiatives are interconnected. Each represents both a policy obligation and a moral responsibility to the people we serve. The Medicaid Assistance Program remains one of the territory's most essential programs, providing health care coverage to approximately 18,729 residents, representing a large share of the territory's population. For many of our residents, Medicaid is not simply an insurance card. It is access to chemotherapy, dialysis, cardiac intervention, behavioral health services, pediatric specialty care, and life-sustaining medications that would otherwise be financially unattainable. The stability of this program is therefore both a fiscal responsibility and a human one. DHS is engaged in a comprehensive state plan gap analysis designed to consolidate and modernize the Virgin Islands Medicaid State Plan. Over many years, amendments were developed in both paper-based and online formats, resulting in a fragmented structure that makes it difficult to present a single, consolidated, authoritative version of the plan. We are currently compiling all existing state plan amendments into one complete and unified document. In 2025-2026, DHS undertook one of the most extensive state plan modernization initiatives in its history. These works include consolidating decades of SPAs into a single authoritative Medicaid state plan, conducting a full gap analysis to identify outdated, missing, or inaccurate provisions, prioritizing amendments that impact compliance, reimbursement, and eligibility, and enhancing transparency by preparing a publicly accessible consolidated state plan. To date, DHS has indexed 147 historical SPAs across paper and electronic formats, identified 62 SPAs requiring consolidation, and flagged 18 provisions as outdated, including rate methodologies and eligibility references, and determined 11 sections requiring full rewrite for federal compliance. We anticipate having a consolidated version prepared by April 2026, after which it will be made publicly accessible to improve transparency and stakeholder clarity. Beyond consolidation, we are conducting a detailed review to identify any missing, outdated, or inaccurate provisions within the state plan. This review is expected to continue throughout most calendar year 2026. At the conclusion, the department will have a prioritized roadmap of remediation activities to guide future amendments and program improvements. In addition to the gap analysis, the department recently secured federal approval of a significant state plan amendment addressing interventional cardiology IC services. This amendment updated the reimbursement methodology for on-island physician payments for highly specialized cardiac procedures, including cardiac catheterizations, angioplasties, and stent placements. The goal of this amendment to increase cardiac specialty physician participation in the Medicaid program, thereby improving access to life-saving cardiac care within the territory. This SPA will serve as a pilot and possible blueprint to examine an alternative Medicaid reimbursement model that may be used for additional medical services for our members. Evaluating the IC model, SPA will ensure that GVI is able to afford local matches annually in comparison with availability of federal claim dollars. The amendment became effective December 1st, 2025, and was approved by CMS on January 30th, 2026. By strengthening reimbursement alignment with Medicaid's fee schedule, we anticipate improved provider recruitment and retention, reduced reliance on off-island transfers, and enhanced cardiovascular health outcomes for Medicaid beneficiaries. The department is also evaluating a high-priority state plan amendment concerning the local poverty level used to determine Medicaid eligibility. The Virgin Islands Local Poverty Level, LPL, has not been updated since 2017. DHS is assessing the feasibility of aligning eligibility with 100% of the federal poverty level, including fiscal impact on the cap federal allotment, long-term sustainability within the Section 1108 framework, and required eligibility and MMIS system updates. This analysis includes evaluating long-term sustainability within the territory's cap, federal, Medicaid, and CHIP allotments and available local resources. As of the close of federal fiscal year 2025, the Virgin Islands had approximately $48 million remaining in its Section 1108 allotment authority. Any eligibility expansion would require formal CMS approval and system updates to ensure accurate implementation. Our objective is to be responsibly increase access to care while maintaining fiscal discipline within the cap funding structure. Additionally, the department is planning a state plan amendment to establish a cost-plus payment methodology for inpatient hospital services provided outside the territory, particularly in Florida. This initiative is currently in the planning stage and will involve coordination with hospital payer negotiation experts to develop a reimbursement structure that more accurately reflects actual resource utilization for higher acuity patients while maintaining administrative clarity and sustainability. Beyond these major initiatives, the department is advancing several additional state plan amendments in 2026 to strengthen program clarity and compliance. These include amendments addressing application methods, behavioral health and clinic services, justice-involved youth coverage requirements under Section 5121 of the Consolidated Appropriations Act, rural health clinic reimbursement methodology, dental service clarity, and transportation coverage standards. Each of these amendments is prioritized based on operational capacity, compliance urgency, and anticipated program impact. Complementing this state plan to work, the department is formalizing Medicaid provider manuals to ensure policies governing coverage, billing, enrollment, and compliance are clearly documented and publicly accessible. Manuals for physician services, applied behavioral analysis services, provider enrollment, and general information have been developed, with public comment processes incorporated to allow stakeholder input. This effort enhances transparency, strengthens providers' understanding, and improves program integrity safeguards. Collectively, these Medicaid initiatives reflect a deliberate shift toward modernization, compliance strengthening, improved provider participation, and expanded access to care. While the work is complex and resource-intensive, it is essential to ensure the long-term stability and credibility of the Medicaid program in the Virgin Islands. Long-term care strategy, borders, and CMS-certified facility development. While Medicaid modernization strengthens access to medical services, access to appropriate long-term placement remains one of the territory's most urgent structural health care challenges. The issue of hospital borders is a direct symptom of the territory's limited long-term care capacity. On average, 7 to 10 medically stable individuals remain hospitalized at any given time because they cannot be safely discharged into our community. Although these individuals no longer require acute medical care, appropriate residential placements are unavailable. As a result of lack of discharge, The territory's hospitals are incurring the cost for all of their daily food and ancillary services without CMS reimbursements. Across our hospitals, there are mothers recovering from strokes, older men who can no longer live safely on their own, and individuals with disability who have completed their medical care, all are waiting in the same way. These are patients who should be transitioning into long-term care settings, but instead remain in acute care beds simply because the territory lacks adequate placement options. Without sufficient capacity across the continuum, hospitals are forced to function as de facto long-term care providers, a costly and clinically inefficient outcome that also places emotional strain on patients who deserve placements in environments designed for long-term living rather than acute intervention. While the Department of Human Services does not operate acute care hospitals, we recognize that discharge bottlenecks disproportionately impact elderly and medically vulnerable residents. Addressing this challenge requires coordinated investments in bed utilization, staffing stabilization, facility readiness, and regulatory compliance. At Herbert Grigg Home for the Aged on St. Croix, the facility is currently operating with 20 residents and 5 available beds within a total 40 beds capacity. We currently have 5 applications pending. The department continues to prioritize the use of existing capacity, recognizing that vacant beds represent both a fiscal inefficiency and a missed opportunity to help relieve hospital discharge congestion. However, the limited availability of 5 beds is directly tied to current staffing levels rather than physical space constraints. I do believe we have some updated numbers in regards to our bed coverage, and we can provide that at the end of our testimony. While the infrastructure can accommodate significantly higher occupancy, safe operations and regulatory standards require appropriate clinical coverage and direct care staffing ratios. With adequate staffing support, the home could make up to 20 beds available for placement. In fiscal year 2025, the legislature appropriated dedicated funding to support operational capacity expansion. This appropriation is being directed towards staffing stabilization and bed activation to expand placement options for medically stable individuals awaiting long-term care. The department has begun deploying these funds to strengthen clinical coverage and direct care staffing levels necessary to safely increase occupancy. Recent hires of 2 licensed practical nurses and 3 certified nursing assistants represents the first phase of this expansion effort, with additional recruitment actions underway. Because long-term care facilities must operate within strict clinical staffing ratios and regulatory standards, bed activation occurs in deliberate phases aligned with workforce onboarding. At Queen Louise Home for the Aged on St. Thomas, the relocation of residents to the temporary accommodations at Palms Court, Harborview, was executed successfully on January 22nd, with resident safety as the primary consideration. The decision to relocate was not taken lightly. For elderly residents, stability of the environment is deeply important, and every logistical decision was evaluated through the lens of safety, continuity, and the emotional well-being of our clients, their families, and our community. Queen Louise Home currently has 13 residents and 3 available beds with 3 applications pending. Operational continuity has been maintained, and admission packages are being finalized in coordination with Adult Protective Services to ensure that available beds can be allocated appropriately to both hospital-based and community-based applicants. The department's approach to addressing hospital boarders is twofold. In the short term, efforts are focused on maximizing existing bed capacity, stabilizing staffing, completing pending social studies, and improving placement coordination. In the long term, the department is embedding CMS certification requirements into facility design, operational planning, and workforce development. CMS certification cannot be retrofitted. It must be planned and funded from the outset. That reality requires us to move deliberately, responsibly, and with long-term sustainability in mind. Federal childcare funding and Head Start updates. Just as we work to protect the dignity and safety of our seniors, we are equally committed to investing in the earliest years of life. The Virgin Islands Department of Human Services, Office of Head Start, has been the Head Start grantee for the United States Virgin Islands for more than 50 years. As a long-standing grantee, DHS administers the Head Start program through consecutive, competitive federal grants. The agency must recompete for these grants every 5 years and must apply annually for continuation of funding. Head Start mission is to promote the school's readiness of children from low-income families who are 3 years old by December 31st up to 5 years old at enrollment. The program exclusively serves children ages 3 to 5. For many families, Head Start represents far more than early education. It provides structured learning, nutritional support, developmental screening, and family engagement services that help stabilize households and prepare children for long-term academic success. To clarify the early childhood continuum within the territory, private childcare facilities licensed by VIDHS serves infants to pre-kindergarten. Early Head Start, operated by Lutheran Social Services of the Virgin Islands, serve pregnant women and children from birth to age 3. Head Start, operated by VIDHS, serves children ages 3 to 5. Granny preschools, operated by Education, serve children ages 3 to 5. Children then transition to kindergarten at age 5. It is noteworthy that Office of Child Care, Head Start, and VIDE host a pre-K to kindergarten transition conference annually for parents and guardians of children transitioning to kindergarten. Head Start provides high-quality early childhood education for eligible children who might or otherwise remain at home and unengaged, and it serves as a family empowerment model that encourages parent participation in all aspects of the program, including governance. Parents serve on the Head Start Policy Council, a federally mandated and influential body comprised primarily of parent representatives. For working parents, Head Start provides safe, comprehensive, early learning services for parents seeking to enter the workforce. The program offers volunteer pathways and training opportunities that often lead to gainful employment. Children enrolled in Head Start benefit from a holistic focus on early learning, health, family well-being, and wraparound support. The VIDHS Head Start program's federally funded enrollment is 794 students. Distribution was established based on community need assessments and facility capacity available at the time of grant application. St. Croix has 500 children in 25 classrooms. St. Thomas, 274 children in 13 classrooms. St. John, 20 children in 1 classroom. Current enrollment is 587 students, reflecting St. Croix 338 children in 19 classrooms, St. Thomas 236 children in 12 classrooms, and St. John 13 children in 1 classroom. The enrollment variance reflects the temporary closure of 6 classrooms due to staffing shortages and a limited wait list in the St. Croix district. Recruitment efforts remain ongoing to restore full classroom capacity. Head Start regulations requires that 10% of enrollment serve children with special needs. Currently, 67 enrolled children qualify through either an individualized family service plan, the IFSP, 14 children, or an individualized education plan, IEP, of 53 children. An additional 41 children are suspected of having special needs and are pending evaluation by the Virgin Islands Department of Education. These children receive services including speech therapy, occupational therapy, and resource support from providers who serve Head Start centers directly. DHS secured $42 million in federal funding to rebuild 6 facilities damaged by Hurricanes Irma and Maria. Each site is being reconstructed to modern, resilient standards, ensuring safe, durable, and developmentally appropriate learning environments for children and families. Construction progress and timeline. Cruz Bay St. John, construction completed December 2024. Educational services resumes September 2025. Projected completion dates for Anna's Hope is April 20th, 2026. Concordia, April 20th, 2026. Benita Mitchell, May 5th, 2026. Bolongo Bay, May 5th, 2026. Lindbergh Bay, May 5th, 2026. In addition, 6 Community Electrical Innovation CEI grant applications were submitted for Anna's Hope, Frederickstead, Cruz Bay, Richmond, Savannah, and Sugar Estate. All sites advanced past eligibility review and completed site visits. If awarded, the grants will support installation of solar panels and battery backup systems to reduce outages, harden infrastructure, and strengthen energy resilience at Head Start facilities. Childcare and quality investments. Supporting working families while strengthening provider sustainability. The Office of Childcare and Regulatory Services administers the Territory's Childcare Development Fund subsidy program, commonly referred to as Block Grant. This program provides childcare subsidies to eligible applicants that are working, volunteering, or are enrolled in training or school for a minimum of 30 hours per week. The subsidies represent a core support for seasoned working families as well as those entering the workforce, while simultaneously strengthening provider quality and early childhood education workforce development across both districts. At present, OCCRS is serving 727 children across the territory, supporting 602 families who rely on child care assistance to maintain employment, pursue education, or participate in workforce training. Each of these children represents a working parent striving for stability, parents who depend on reliable child care in order to maintain employment, pursue education, or participate in workforce training. The current reimbursement rates are structured to reflect age-based care costs. The territory currently pays child care subsidies in the 100th percentile of child care costs based upon the 2022 market rate survey and narrow cost analysis of data provided by local child care providers. Infants, $600 per child; toddlers, $675 per child; preschoolers, $725 per child; after school care, $429 per child. On average, participating providers receive between $18,000 and $20,000 per month in subsidy payments, depending on enrollment levels and age distribution. Within the territory, there are currently 105 licensed child care providers, 56 licensed child care providers on St. Croix, 49 licensed child care providers on St. Thomas. Of those licensed providers, 48 are actively participating in the subsidy program. 24 providers on St. Thomas receiving subsidies and 24 providers on St. Croix receiving subsidies. In addition to the licensed formal child care providers, OCCRS supports informal child care providers. These are participants in our Family, Friends, and Neighborhoods FFNS program, which allows for subsidy support for child care provided by non-professional providers such as family, friends, and neighbors. Quality and workforce initiatives include the launch of the Infant Toddler Micro Badge Credential Program, the annual Infant Toddler Conference, the annual Pre-K to Kindergarten Transition Conference in partnership with Head Start and the Department of Education, and the relaunch of the Quality Recognition and Improvement System, QIS. Homes for the Aged. The Department of Human Services is executing a dual-track strategy for both the Queen Louise Home for the Aged on St. Thomas and the Herbert Grigg Home for the Aged on St. Croix, stabilizing current operations while advancing long-term redevelopment designs to restore CMS-certified nursing facility capacities in the territory. On January 22nd, 2026, residents of the Queen Louise home were safely relocated to Palm Courts Harborview Hotel to allow for necessary structural and environmental repairs to the existing facility. The relocation was carefully coordinated to ensure continuity of care, with residents immediately resuming meals, medication management, and daily supervision under the same Queen Louise nursing and support staff. Senior Citizens Affairs leadership remains actively engaged in daily oversight at the temporary site. Queen Louise home is currently staffed by 1 registered nurse serving in a volunteer capacity and 1 part-time registered nurse, 4 licensed practical nurses, and 13 certified nursing assistants, supported by 1 laundry attendant, 2 custodial staff, and 1 CSEP worker in institutional support, 2 cooks, 2 food service workers, and 2 CSEP workers in the kitchen, and administratively by 1 chauffeur and 1 relations coordinator and 1 CSEP employee. The Palm Court Harborview Hotel location was selected based on its ability to meet residential care requirements, including ADA compliant accommodations, secured access controls, generator backup power, adequate dietary capacity, communal space for visitation, and telecommunications infrastructure. Residents are expected to remain temporarily housed for approximately 9 months, pending completion of repairs and final regulatory clearance. The 4-tier pre-design assessment identified significant structural, mechanical, electrical, plumbing, and life safety deficiencies, and confirmed that while portions of the facility remain serviceable, major building systems have reached or exceeded their useful life. Identified priorities include comprehensive upgrades to HVAC systems, electrical distribution infrastructure, fire alarm and suppression systems, roof assemblies, and plumbing lines. In addition, the report highlights the need to reconfigure residence room, improve ADA accessibility, enhance infection control layouts, and modernize nurse stations and clinical support spaces to align with contemporary long-term care standards. Beyond immediate infrastructure stabilization, the department is advancing a long-term redevelopment strategy. The planned rebuild on a newly acquired parcel of land near the Royal Snyder Hospital has entered the 30% schematic design phase in coordination with the Office of Disaster Recovery and Super Project Management Office. The redevelopment strategy is structured around layered federal recovery funding streams. FEMA Public Assistance PA funding has been secured for eligible temporary repairs and stabilization work. A FEMA PA amendment for temporary relocation support was approved on October 3, 2024, ensuring financial coverage should phase transition become necessary. These coordinated funding mechanisms ensure compliance with federal recovery and procurement requirements. The rebuild is not a renovation of the existing structure. It represents a foundational expansion of long-term care infrastructure. The new facility is being designed to meet federal CMS conditions of participation for nursing facilities, positioning the territory to reestablish Medicare and Medicaid certification. This will allow for sustainable reimbursement of participation and bringing the territory back into alignment with national standards for long-term residential care. The Herbert Gregg Home continues to operate as a 24-hour residential skilled nursing facility. Clinical services are overseen by 1 registered nurse and supported by 8 licensed practical nurses who manage medication administration and daily medical needs, while 13 certified nursing assistants and 1 nursing assistant provides hands-on support with activities of daily living and routine monitoring. Operations are further supported by 3 laundry workers and 1 institutional attendant who maintain sanitation and upkeep, along with a food service coordinator, 2 cooks, 1 institutional food service worker, and 3 food service workers who manage meal preparation and services. 3 CSEP employees also assist across operational areas. DHS is actively advancing plans to construct a modern, CMS-certified long-term care facility on the south side of Herbert Quick property. A federally funded pre-design and feasibility assessment was completed to evaluate structural integrity, code compliance, floodplain considerations, and long-term operational sustainability. The assessment confirmed that full redevelopment rather than piecemeal renovation is the most viable path toward ensuring a resilient, code-compliant, and potentially CMS-certifiable long-term care facility. The redevelopment of Herbert Grigg is supported through a layered disaster recovery funding structure, including FEMA public assistance funding for eligible repair and replacement components, approved FEMA amendments supporting temporary protective measures and stabilization, and coordination with the Office of Disaster Recovery and the Super Project Management Office, SPMO, for capital project oversight. These funding mechanisms collectively positions the territory to transition from temporary repair efforts to long-term, purpose-built facility designed to meet modern standards of safety, infection control, accessibility, and operational efficiency. The department's objective is not merely to restore pre-storm conditions, but to construct a facility capable of meeting enhanced regulatory requirements, addressing future long-term care demand, and supporting improved clinical and residential outcomes for early residents. The redevelopment plan also incorporates design considerations necessary should the territory pursue CMS certification in the future. HGH reconstruction is therefore being approached not as a repair project, but as a strategic long-term care infrastructure investment for St. Croix. Nude Hansen permanent redevelopment. The permanent reconstruction of the Nude Hansen complex is progressing under the leadership of the Super PMO and Springline Architects, the selected design build contractor, with architectural and engineering plans currently in development as part of the Rebuild USVI portfolio. The project is a full ground replacement of the former facility with architectural and engineering plans now in the development for a new 4-story purpose-built complex that will house both the Department of Human Services and Department of Health Operations. The design incorporates a modern DOH-operated community health clinic on the second level, along with consolidated DHS administrative and client service space to support an integrated approach to public health and human services. Procured as part of a bundled design build package, the project structure is intended to maximize delivery efficiency and align long-term infrastructure investments across government programs. The 30% design milestone is anticipated in late March 2026, a key checkpoint for finalizing program scope, validating cost models, and confirming construction sequencing. Once completed, the rebuilt Nude Hansen complex will centralize critical DHS programs currently spread across multiple temporary sites, allowing for improved client service, streamlined service delivery, and enhanced disaster resilient operations. The redevelopment reflects the territory's long-term commitment to modernizing public service, infrastructure, and ensuring continuity of care for the community. As designed and planning advanced for the permanent Nude Hansen facility, the department has secured temporary lease locations to maintain seamless service delivery. All leases have been fully approved and executed. 2 temporary sites are being utilized: Tutor Park Mall, which is the old Via building, and Haven site. The Haven site location is being executed in phases and is designated for non-client facing divisions. Phase 1 is complete, and the site now houses the Medicaid Program Integrity Unit, Human Resources and Operations Division. At Tutor Park, the department is awaiting completion of the interior build-out to allow staff to transition into a centralized, planned, accessible location. This site is particularly advantageous due to its proximity to public transportation and its accessibility for clients requiring in-person support. To put things in perspective, the Nude Hansen Memorial Hospital building in St. Thomas began construction in the 1940s and opened in 1953. That was 73 years ago. It was built for a different era under different standards and for a completely different purpose. It was constructed as a hospital in the 1950s, long before modern building codes, long before ADA standards, long before the technological infrastructure required to administer federal programs, and long before the health and safety compliance environment that governs human services today. It was never designed to house the administrative backbone of a 21st century Department of Human Services, and yet for decades our employees have shown up to work every single day and delivered services from that facility. Not yesterday, not 2 years ago, for decades. We know it's old, our employees know it's old, the public know it's old, and at this point, even the building knows it's old. We have seen Facebook Lives, we have seen videos circulating that highlight portions of the surrounding property, some of which are not even under jurisdiction of Department of Human Services, framed as though the conditions develop overnight. Let us be clear. This structure did not deteriorate last week. It did not become outdated this year. It has been aging for generations. But here is what is different now. For the first time in a very long time, this is not simply a talking point. It's an active redevelopment effort. Interim leases have been secured. Planning and design coordination are underway. Funding alignment is in motion. Permanent redevelopment is advancing through formal procurement and project management channels. Our staff deserve better than a 1953 building. Our clients deserve better than a 1953 building. And we are no longer managing the limitations of that facility. We are moving to replace it. We are here and we are moving forward. Chairman Fonseca and members of the committee, the Department of Human Services operate at the intersection of policy, vulnerability, and public trust. Every program discussed today, Medicaid, long-term care, childcare subsidies, Head Start, facility redevelopment, represents more than a line item or construction timeline. It represents a mother in Campo Rico waiting for childcare to be able to go to work, a senior in Snyder Regional waiting for dignified long-term care, a child in St. John waiting for early education, a provider on a network waiting to be paid, an employee in Charlotte Amali who shows up to work every day in a building that has long exceeded its useful life. We are managing inherited structural challenges, yes, but we are not managing them passively. We are stabilizing Medicaid. We are expanding and modernizing long-term care capacity. We are rebuilding Head Start centers with resilience and sustainability in mind. We are strengthening childcare systems. We are consolidating and redeveloping facilities that have been outdated for generations. These are not cosmetic adjustments. They are structural corrections. The work is complex. The funding layers are intricate. The regularity environment is unforgiving, but the direction is clear. The department is not standing still. We are building systems that can withstand storms, literal and fiscal, and that can serve this territory not just this year, but for decades to come. Oversight matters, partnership matters, accountability matters, and we welcome all three because the mission is larger than any hearing, fiscal year, or administration. At the end of the day, the question is simple. Are we leaving the system stronger than we found it? That is the standard we are working toward. We thank you for the opportunity to address this body, and we are prepared to answer any questions you may have. Thank you.
Thank you, Commissioner Earle George, for that detailed and very well organized and presented testimony. I like the graphs and the pictures. It shows that the Department of Human Services is involved in many, many programs. I think in the government, correct me if I'm wrong, I think Human Services administers the most number of federal grants. So I know that you're busy. I want to note for the record that we have received a testimony from the Disaster Recovery Office presented by Adrian L. Williams Octalian. I'm not going to read it into the record because no one is here to answer any questions, but Senators, it has been received. We're going to make sure it's distributed. So I want to start real quickly. And the state plan update is, it was very well put together. Question, you have a list of amendments you mentioned that you'll have in draft form. I just want to clarify, I think it does not need legislative review or authorizations. Correct me and let me know if the state plan can be done through the Department of Human Services without authorization from the legislature.
Senator, I'll let Mr. Gary Smith, who's in St. Thomas, would you answer that question? Either him or Assistant Commissioner Tasha Dorset.
Good morning, Gary Smith, Medicaid Director. That's correct, Senator. No legislation is necessary to submit a state plan amendment.
Okay, so you do have a date that you plan to submit the update, and we would like to get copies as soon as possible when it's been finalized. One particular question in the state plan, I have a question regarding the locum physicians being able to bill, or the government being able to recoup the hospital services. How is that being addressed?
Gary Smith, Medicaid Director. So as the Commissioner indicated in her testimony, we just received authorization for the interventional cardiologist SPA state plan amendment, which allows us to pay the IC physician for those fees as he's an employee of the hospital.
Okay, I know Senate President Milton Potter had sponsored a bill in the 35th legislature to authorize the funding for the intervention cardiologists. I guess when health department comes, when the health department comes, the hospitals comes later on, we can find out if that position has been filled. Because if you're telling me now that there'll be additional funding resources, that would be good. It's always good. Heart care. Yes, Assistant Commissioner Ms. Dorset Phillips.
Good morning, Senator. Tasha Phillips Dorset. I wanted to add one comment on to Director Smith. So the pilot that Director Smith mentioned for interventional cardiology, it doesn't provide additional services to the hospital. What it allows the hospital to do is bill Medicaid outside of the approved bundled inpatient daily rate for the services provided by that specialty. So the actual interventional cardiologist would be paid separately via a separate claim than the services that are currently provided by the hospital via the daily rate. There are a lot of questions, comments, and concerns that we get at the Medicaid program regarding why can't we use a similar methodology for all of those hospital-employed physicians. The point is we're being very prudent with this pilot program, because if we open up the floodgates, then we will need additional dollars for the general fund portion of the claims match. We are capped in federal funding. We're about $142 million right now annually. And most of the claims are split 83%, 17%. Some of them are 90-10, and some of them are 85-15 for children. So we know we are in a fiscal crunch. We've watched the revenue estimation conference that we had recently, and we know that the government is about $140 million in the hole. So we don't want to expand to cause an additional general fund burden that we know DHS cannot afford because we have a capped ceiling. Thank you for that additional time.
Thank you. I'd like to welcome the Honorable Senator Clifford Joseph. Welcome non-committee member, Senator Clifford Joseph. So colleagues, we're going to go to point of, and also Senator Carla Joseph, the Honorable Rules Chairwoman. Welcome, Senators. Point of information, Senator Kurt Ville.
Thank you so much, and good morning to the people of the Virgin Islands. Good morning, colleague. Good morning to the testifiers. In reference to the amount of federal dollars allocated for Medicaid, you said that amount is 142 million.
For the claims, but I defer to Director Smith.
For the claims, Director Smith, 142 million.
$143,600,000.
Okay. And we exhaust 143 million every year?
The allotment increases per the CPIU, the medical component of the CPIU each year, which since my tenure 8 years, it has never gone over 2.01%. So next year it'll increase by 2.01%.
Did we exhaust the amount allocated to the
No, we
Virgin
did
Islands? We did not.
No, the commissioner stated in her testimony that we did not expend $48 million of that last fiscal year.
Okay. During my time, I'll
Yes, I want to follow up on that. So based on that statement, the account payables, the Medicaid program, what is the balance doing account payables for Medicaid program? Are all the bills paid or you have a balance? What is that?
Currently, we have vendors that are owed. We do have outstanding accounts payables.
Approximately how much?
Vendors, I would say.
We have the CFO right here. Can the CFO give us that amount?
Okay, I'll ask the CFO, but to my knowledge, I'd put it at like about $8-9 million, and that includes federal and local funds.
Lydia McGrath Purcell, Chief Financial Officer. That is not with the Gainwell claims. That's contractual costs from prior years that were not captured, including some of this year.
What's the number?
I'll give you the exact number because, Gary, do you have a number for claims?
For claims, well, we've paid to date $30,722,704.81, and that's for 83,180 claims.
Okay, so while you get that number, I want to just mention a major accomplishment, and I have to, point of admission, Senator Bailey.
We just need some clarity
Yes.
in terms of
Yes.
the total amount. Because you're saying that $48 million was remaining in the section 1108 allotment. Ms. McGrath Purcell.
Lydia McGrath Purcell, CFO. The 1108 ceiling specified is specifically for claims.
For claims.
We also have MMIS. We have eligibility and enrollment funding. Those are separate pots of money.
Okay, so let's stick to the claims.
No.
The $48 million is in reference to claims.
Yes.
And those are claims that was from FY25?
Yes.
Okay.
Gary Smith.
Are you on a calendar or fiscal year?
Fiscal year.
Okay. Do we have any outstanding claims from FY25 that wasn't paid?
Yes.
Okay, and that's what I wanted to know. So what is the correlation behind returning monies for FY25 but having the monies to pay those claims? What was the reason as to why those claims were not paid?
Gary Smith, Medicaid Director. You could have various reasons as to why a claim is not paid.
Now, I want to know specifically for 25.
Well, I mean, that would require a deeper dive as to there may be claims that haven't even been submitted by providers. A provider has one.
Hold up. Well, where I'm going, and
okay.
A lot of time we have bottlenecks in the system. It could be provided by or a result of providers, et cetera, et cetera. But at some point, based on the fact that we have federal dollars to deal with these claims, everybody needs to be doing it on time, to include the providers. So providers can't submit to you claims 5 months past after the fiscal year have ended.
Yes.
Hasn't
Yes,
it?
they can.
They
Yeah,
have.
but okay, they can. So when they do, does it come out of the fiscal year 25 allotment, the 1108 allotment, or they're now taking it out of the 26?
26.
They're taking it
Yeah.
out of the 26?
Yes.
Yes.
That's why I am saying they can't. They must have a cutoff to submit their claims so that we can make sure that DHS is utilizing the federal dollars for that particular fiscal year.
If I may, Senator Gary Smith, Medicaid Director, claims is not when the service was rendered, but when the service is paid for, as far as CMS guidelines. So CMS guidelines allows a provider and the state or territory sets the parameters as to when a provider can submit a claim. Our timeline is 1 year. So, you know, there can be various issues as to why a claim is not submitted in a timely manner, but they have up to 1 year. And then there are also issues where you mentioned the bottleneck. You know, there may have been a system issue when they submitted the claim. The system may not have been operating properly. I mean, there are many and various reasons, as I mentioned. However, you know, we are allowed to pay retroactively 2 years for any type of claim from a provider or vendor.
But my issue ain't what we're allowed to do. My issue is where the money is coming from. And if you're retroactively paying from this year allotment, then that's a different story, because I know you said you're doing the state plan, but there's a lot of concern in reference to charges from the hospitals that they're saying can be captured as a result of the state plan. But I will get into that during my time of questioning. Thank you, Mr. Chair.
Point of information, Lawrence, Senator Fredericks.
To what we're discussing, Mr. Smith, prior period claims that we are currently evaluating, they're not being offset with the current federal appropriations we have. So then you're using current year appropriations, the 2026 monies, to pay 2025 claims. So then it burdens the 2026 budget. We just came from that revenue estimation conference on Friday, and the OMB director said we are burdened with over almost $50 million worth of unplanned obligations. This is one of the reasons why the system is failing us, because we are not matching expenses in the year that we provide the services or the revenues for that year. No normal entity could function properly that way. So what we need to get to at some point today is how can we make this process more efficiently so that we don't get stuck in this rut of always trying to pay last year's money with this year's new allocation. It won't work.
So Gary Smith, Medicaid Director, you know, one thing that would assist is if we can pay the providers more consistently. The last payment that went out to all providers was sometime back in February. So it's nearing, this week it'll near 30 days since we've made a payment to all providers. However, we are able to pay the public facilities, meaning the 2 hospitals, the FQHCs, and the Department of Health clinics, because we only pay them the federal share. They are reimbursed on by the federal share based on a payment model called certified public expenditures, which a state plan amendment was submitted back in 2015 and approved because the public facilities are receiving general funds from the government. CMS allows you to reimburse them the federal share. They are supposed to account for the local match from the funds that they receive from the general fund.
You know, I want to follow up on that. And colleagues, we're going to go to a round of 6 minutes, but I just want to follow up on that question. And Ms. McGrath, were you able to get that number so far, the accounts payable for Medicaid?
Lydia McGrath, Purcell, CFO, I'm going to have the number. The thing with the MMIS and the E&E payments that are outstanding the federal government is providing 75 and in some cases 90% of that funding. So the burden does not fall squarely on the general fund.
Okay,
So,
I want to follow up
Yes.
on that specific because you administer both the general fund and the federal funds, right? You pay bills for the Medicaid program and for the regular human services program.
The claims processing.
No, just answer me yes or no. You pay both the bills for the human services, which is general fund, and also the Medicaid, the federal funds.
Comes out of the budget, yes.
Okay, so is there any case where the funds are commingled? In other words, a Medicaid bill is due, but you pay a general fund bill with it, and then when you get reimbursed, you don't commingle the federal and the local funds?
No.
What's your total drawdowns balance right now? Do you know that?
I will have to pull that, but with the Medicaid claims.
Yeah, I understand
we
that.
are allowed to draw the funds prior to the transaction.
Yes, I understand
It's
that.
not a burden on the general fund in any way, shape, or form.
Yes.
So when Gainwell sends the file to finance, the fiscal office is copied, and then once the file is uploaded into the Department of Finance's ERP system, we pull the numbers, we perform the draws. Once the funds hit Treasury, then finance issues the checks.
Yes, but Ms. McGrath, please answer the question that I'm asking you. I didn't ask you for the detailed dissertation on that process. All I wanted to know was what is the federal funds drawdown balance? Do you have that?
I'm unsure. When you say the federal funds
You
drawdown balance,
don't have any drawdowns balance because remember, part of the issue while Human Services was in the consent decree with education and the Department of Health was implementing and improving systems so that we could improve the cash flow coming into the federal government. And I know Human Services has a lot of federal funds. So what is the balance and the procedure for the drawdowns? I want to see how it's operating in the systems.
overall for the government, for the entire department,
Yes.
or for Medicaid,
No, for the whole department.
we draw the funds as soon as the checks are cut. So when a check run happens on a Tuesday, the staff prepares the draws and they perform them Wednesday morning.
Okay.
So then the checks are released once the
So it's
draws.
less than 2 days, you're telling me?
Yeah, and for payroll, we do it the same day. If payroll generates on Thursday, we prepare the draws for Thursday and draw the funds.
Okay, good. I'm glad to hear that. So, colleagues, the lineup is going to be Senator Hubert Fredericks, Senator Kurt Valet, Senator Milton Potter, Senator Alma Francis Heiliger, Senator Clifford Joseph, and Senator Carla Joseph. Senator Hubert Frederick, you're recognized for your 6 minutes.
Thank you very much, Mr. Chair. A pleasant good morning, colleagues, testifiers, listening and viewing audience, my office, central staff. Really happy to have the opportunity to speak to the Department of Human Services today. Very important agency, and one that covers a lot of critical services for our community. Commissioner George, how you doing today?
I'm doing fine, Senator.
Thanks for blessing us today with your presence and having your team here. Wanted to talk some more about the border issue with the hospital. You touched on it in your testimony. I see we're making progress in terms of hiring staff. Where are we in terms of getting some more capacity at Herbert Gregg, in particular on St. Croix, to get that facility up to near capacity? Because I think you said it was a 40-bed facility in your testimony.
Senator, we're currently going through the process of hiring additional staff. Sorry, Commissioner Avril George. We're currently going through the process of hiring additional staff and getting the beds available to take in more individuals, not only boarders but members from our community. It's an ongoing process. I think in Herbert Gregg, we have taken boarders from the hospital. If I'm not mistaken, I think I'll ask Kishma Vincent to update you guys based on the information provided in the testimony. How much borders does Wang Louis currently have? Ms. Vincent?
Good morning, Kishma Vincent, Administrator, Senior Citizen Affairs. Currently, our border count that's eligible for the Herbert Grigg home on St. Croix is 1. So 1 from Wang Louis.
And I think they had around 5 or 6 currently.
We have taken
you have
some of them and some of them have passed.
You have to look at those that are eligible for admission. So that's why I said eligible. We have one female.
So educate us on that process. Once the border is identified, do they contact Human Services right away, and then you do your evaluation to see if they qualify for placement?
Yes, through our Adult Protective Services Department, we do an intake, we do an evaluation. Part of that is, of course, they have to be seniors, so they have to be 60 and over in order to qualify. They have to. We are not a skilled nursing home, so we also have to look at their needs to see if we are able to handle their needs. So that's part of the process.
So, Commissioner, I was told that they typically just dump them. Some family will just leave their family members in the hospital, and at that point, they're indigent, I assume, and so we have to figure out from there where to go, right?
You're correct. But I'll have the hospital give you more in depth of their processes when they come before you. Our DHS only concern in assisting the hospital is who qualifies for Department of Human Services facility based on our requirements and if available space is there. Other than that, we're not involved with all borders. We just go on a basis of who meets our qualification to be placed in our facilities.
In your testimony, you spoke about cardiology being the new basis of Medicaid reimbursement. Family planning seems to be a broader spectrum of services that we have a need for. Did anyone consider family practice as being one of the areas we wanted to address as well to see if we could get our reimbursement from Medicaid?
If I'm not mistaken, DHS goes by what is federally approved for a significant state plan. We don't get the ability to choose what services should be in there. I'll have Mr. Smith expound on that.
Gary Smith, Medicaid Director. Could you repeat the question, Senator, please?
Yes. So in the testimony, we spoke about cardiology being the new state plan focus, so we could try to extract more Medicaid payment. I was thinking about why is it we didn't also pursue family planning, because that's a broader spectrum of services that we need, diabetes, everything else that goes in there, and that would help us a whole lot.
Gary Smith, Medicaid Director. So, that's part of the gap analysis for our state plan. And, those areas where we need to add services to be able to, provide additional access to care for the community and our citizens is being performed during in that gap analysis of the state plan.
The gap analysis, does it specify a time-sensitive period that we're going to start pursuing other aspects?
Yeah, the gap analysis is going to continue through this calendar year, and as the issues come up, they are brought forward, and we prioritize, which areas we need to take action on.
I kind of wish we were meeting next month or May, because it seemed like the deadlines. Mr. Chair, if I could just conclude.
Yes.
Most of the deadlines I see in the testimonies are coming up in the next 60 days, but we'll have an opportunity again to follow up on those benchmarks to see where we are with the state plan. Thank you very much, Mr. Chair, for the time. Thank you very much for your responses.
Yes, thank you, Vice Chair Senator Fredericks. Okay, you know, I wanted to discuss quickly the Head Start because I think this is a major accomplishment, and I would like to, you know, say publicly that I think the Human Services Department is a very competent department. You're very well managed, and in my second term, I can see the vast improvement in this department. So the 5 Head Start buildings, I want to ask you about the Bolongo one. It's scheduled to be completed on May 5th. So I note in your testimony on page 6 where you said you were funded for 794 students, and I think your enrollment is about 587. So it shows that you have a capacity, you can accommodate about 207 more or less. How many are going to be in each of the facilities, of the 5 Head Start facilities? Do you have the numbers? The Anna's Hope.
I'll report a question to Ms. Lewis on your St. Thomas and Ms. Lewis.
Masika Lewis, Administrator for the Office of Head Start. So for Bolongo, that will accommodate 80 students on St. Thomas. Lindbergh Bay will accommodate 20 students on St. Thomas. Minetta Mitchell is going to be a nutrition storeroom and administrative building. On the St. Croix, the Concordia site will accommodate 20 students, and the Anna's Hope site will be administrative building for the St. Croix District Office of Head Start.
Okay, so that's a total of 120 Head Start students, 80 plus 20 plus 20, 120. So those are going to be new students, or some Head Start going to transfer from some of the other facilities?
So for the Bolongo site, we will be closing the Wilhelm George Center. And so those students will move over to the Bolongo site. And of course, currently, Wilhelm George will normally hosts 76 children, but that number will be increased by 4. So Bolongo will now host 80 students. And in Lindbergh Bay, which is on the western side of our island, they will host 20 students. And on St. Croix, for Concordia, that would be an additional 20 students.
Okay, that's a big facility, Bolongo. So the water, how are they going to get water? They have cisterns, the building is built with cisterns, or you're going to have, because I don't think there's any potable water over there, right?
So that particular site, we do have, it's not cisterns, but we do have water tanks that are at the Bolongo site as well. So we have quite a few of water tanks there. I do think there is some potable water there as well. I can verify. But we do have water tanks as emergency systems in all of our Head Starts.
Okay, 80 students. So you're talking about plastic water tanks, concrete, what type of water tanks you talking about?
So I will get the logistics of that information for you, exactly how much water tanks and what material is used for it.
Okay, thank you. Senator Kurt Vele, you're recognized for your 6 minutes.
Thank you, Mr. Chair. Do we presently have anyone on the waiting list for Head Start?
Yes, for the 2025-2026 school year, we currently have on St. Thomas for the wait list 110 students, on St. Croix 13, and on St. John 1.
Okay, on St. Thomas 110, St. Croix 13, St. John 1, and that as a result of not having sufficient space.
Specifically for St. Thomas, that comes down to not having sufficient staff. On St. Croix, we are actively recruiting, so that on St. Croix...
So hold up. So St. Thomas, you have the space for the 110, but you don't have the staff?
We have, yes, we have approximately about 3 different classrooms closed on St. Thomas and 3 on St. Croix. So we have 6 classrooms that are closed.
And are you recruiting teachers for St. Thomas?
We are recruiting teachers for the territory. Yes, we are.
Okay. So with the additional space that's coming online, staffing is still going to be a major issue.
Yes, staffing is a concern right now.
So we have to be able to fix that staffing issue, or say additional capacity coming online is going to remain unfilled because there's not staff.
We do have positions that are currently advertised. We have completed some interviews as well, but one of our major issues is actually finding staff that are qualified to actually come on board. That's the major challenge right now.
Okay, so that's a major issue, and I just want to put that out there. It's not just capacity, it's just not having a building. It's having individuals to fill the role of teacher and paraprofessional, et cetera, to get those programs going. So we need to see how we could come up with a plan, which is hard because it's all across government, find qualified individuals. And going back to Medicaid, because I just want to dig on issues, hopefully that we can provide some additional services or recoup additional monies. We're allocated $142 million in federal funds, and the federal government expects us to match 17% of that amount.
So on average, it's about 14% for claims.
So the match that they're expecting us then is what, close to $20 million?
I would say yes.
Are you allocated that $20 million in your budget?
No, sir.
So what are you allocated in your budget?
This fiscal year, $9.1 million, I believe, plus a waiver of $1.8 million. So
Okay,
give or
so
take
10.8.
Yeah.
So if it's $20 million to get the entire $142 million and you're only getting 10, then you only have access to 71.
If your numbers, I know you're a mathematician, so probably yes.
So why are you guys not advocating for more money? Commissioner, if we're able to put up $10 million more to get $70 million that could flow into the hospitals, the clinics, providers, why are we not getting a request for a line item to be able to deal with the Medicaid match and increase?
Commissioner George, we have been trying, but it's across government and
Hold on, Commissioner. Hold on. I know that across government, we just come from the same revenue estimating conference.
2 minutes.
But we're looking at not just providing dollars and not getting a return. We're looking at $10 million, allowing us to infuse $70 million more into the healthcare industry, which is less monies that we have to provide to the hospitals, etc. So at some point, Mr. Chair, and for this budget cycle coming up, I would like for Human Services to provide as a line item or an amount that this institution could provide as a line item that would meet the match. Now, you're saying one thing, Mr. Smith, you're saying that for the hospitals, that you consider the match to be the appropriation that we give to them, correct? Do you give the hospital, do you reimburse the hospital the 17%?
No, we do not.
Because you say that the government is giving them an allotment?
Yes, sir.
So what does that equate to? Can that now increase the amount from $70 million? How much does the hospital bill that we're not providing the 17% match that we could add to this?
Yeah, I would have, that would be included in the match amount to maximize and leverage the total funding we're getting from the federal government to pay claims.
Right, but I need to know if hospital claims are $70 million and we're not providing the 17%. That's 17 out of the 142. Yeah. So now, what is 17% of the 71 that is left that we need to match? Because when we meet with the hospitals, and did this committee along with the members of this body, had a meeting with Snyder and we had a meeting with GFL. And at that meeting, some of the doctors had concerns in reference to services that are provided that are not reimbursed because of the state plan. Are there some issues with that?
I'm not aware of any services that are not covered by some services at the hospital.
Let me ask a different question.
Okay.
In your evaluation or reevaluation or reanalysis of the gaps in the state plan, etc. Who are the stakeholders at the table? Do you have individuals on the clinics, the providers, the hospital that are speaking as to areas within the state plan that need to be fixed?
Those meetings will begin in June, Senator, as part of the gap analysis.
Why so long for? Yes, ma'am.
Tasha Phillips Dorset, Assistant Commissioner. Senator, we do get inquiries on several occasions from different medical entities, providers in the community, etc. And when we do get those inquiries, we then meet with our very done project managers. We look at the schedule for the state plans that are already in the queue, and then we try to address. The reason we were able to get CMS to approve the interventional cardiology one at the end of December is because it came as an inquiry from Schneider Regional in about November 2024. So it took us about a year to get that plan amendment crafted and for CMS to approve it. They have about a window of maybe 60 days or so that they take to approve. So we're doing them one by one as they come in.
Okay, we need to speed up the process. But the question I'm asking, have you written to Freddie Said Health Center, East End, JFL, Snyder, as to give you feedback as to recommended changes for the state plan or areas of the state plan that's presently an impediment to them providing service?
Not in a formal setting.
Yeah, Gary Smith, Medicaid Director, we'll take that back as an action item, Senator.
Okay, I think we need to get that done as quick as possible, Mr. Chair.
Definitely.
Can I ask one more question?
Yes,
I was going
you may.
back now to, I guess it'll be HR or my friend, Ms. McGrath.